Welcome to the deep dive. Imagine, if you will, a medical mystery where changing absolutely nothing about a drug,
Right.
except, the actual physical shape it comes in.
Yeah.
Like changing just that could suddenly stop a patient from catching a life-threatening heart infection.
It sounds kind of like science fiction, honestly.
It really does. But we are looking at a fascinating 2026 study from the Journal of Substance Use and Addiction Treatment today. And, it completely upends the traditional clinical equation because usually, you target a specific disease with a specific molecule.
Exactly. You match the key to the lock.
Right. But this research reveals how the delivery mechanism of an addiction medication radically alters a patient's vulnerability to entirely secondary infectious diseases.
Which, I have to say, forces a much-needed reframing of the opioid crisis for all of us, because we are so accustomed to discussing opioid use disorder, mostly through the lens of overdose, right, or behavioral health.
Which are obviously huge issues.
Yeah. Oh, paramount, absolutely. But the underlying narrative of this data shows that opioid use disorder is fundamentally an infectious disease crisis, too.
Yeah.
The pathologies are just completely interwoven, and parsing out how to treat one without, ignoring the other has been this massive blind spot in systemic healthcare.
So what does this all mean?
Hmm.
To understand the breakthrough these researchers are highlighting, we need to map out the sheer scale of the collateral damage first.
Mm-hmm.
The paper lays out this grim spectrum of infectious diseases that are, well, they're inextricably linked to injection drug use. We are talking about chronic viral loads like hepatitis B, hepatitis C, HIV.
Mm-hmm.
But then, there are the acute bacterial emergencies.
Yeah, and the acute infections are where you really see the immediate catastrophic physical toll. The study pinpoints severe skin and soft tissue infections, so things like cellulitis or pervasive abscesses.
That's awful.
They are, and they can escalate rapidly because when unsterilized needles or even just contaminated skin flora introduce bacteria directly into the tissue and the bloodstream.
That's bacteremia, right?
Exactly, you get bacteremia. And if that bacteria circulates and then colonizes the heart valves, well, you develop infective endocarditis.
Oh, wow.
Yeah. Which frequently requires open heart surgery to replace the destroyed valves.
Reading through these clinical outcomes, it's like focusing so much on the structural damage of an earthquake that you completely ignore the fires breaking out in the aftermath.
Oh, that's a brilliant way to put it.
The addiction is the earthquake.
Yeah.
Right? It is the undeniable ground-shaking event. But these cascading infections, the bacteremia, the endocarditis...
They're the fires.
Yes, they are the fires. And if you don't extinguish the fires, the city still burns to the ground.
That analogy perfectly captures the compounding systemic burden here, because when you have an individual battling a severe use disorder and they suddenly require, say, a 6-week inpatient stay for intravenous antibiotics,
Right.
the healthcare infrastructure is stretched to its breaking point. So to extinguish those fires, clinical practice relies on medications for opioid use disorder, or MOUD.
Okay, right.
By stabilizing the neurological cravings, addressing your earthquake, these medications, specifically buprenorphine, are intended to mitigate the chaotic behaviors that lead to those injection-related infections.
Which logically tracks. Like, if the neuroreceptors are satisfied, the patient isn't compelled to inject, and the vector for infection basically disappears.
In theory, yes.
But the central tension of this 2026 paper isn't about whether buprenorphine works. We know it does. It is entirely about how you get it into the patient's system.
Exactly.
Because the researchers pitted two formulations against each other. There's TMBUP, which is the standard daily transmucosal oral dose.
The pill that dissolves under your tongue.
Right. And then there's BUP XR, which is the once-monthly subcutaneous extended-release injection.
And we should clarify, the active pharmaceutical ingredient is identical in both.
Wait, I have to stop you there because, if you look at these pharmacological profiles, you might immediately think there's a mistake. Well, if the molecule, buprenorphine, is exactly the same in both the pill and the syringe, why would the delivery method matter at all for a bacterial infection? Like, a drug doesn't miraculously acquire antibiotic properties just because you inject it under the skin instead of dissolving it under your tongue.
What's fascinating here is the intersection of pharmacokinetics and human behavior. You are absolutely right that buprenorphine offers zero antimicrobial action. None.
Right.
But consider the daily reality of the oral formulation. Maintaining a daily transmucosal regimen requires immense executive function.
But it's hard enough for anyone.
Exactly, and for a patient navigating the intense volatility of early recovery, which is often compounded by, housing instability or fragmented support systems.
Yeah, real life.
Right. Daily adherence is a fragile lifeline.
Because the moment that daily rhythm breaks down, the pharmacology basically turns against them.
The pharmacokinetic drop-off is severe. If doses are missed, forgotten, or frankly diverted into the secondary market, the plasma concentration of buprenorphine just plummets.
Oh, I see.
This creates immediate windows of vulnerability. The patient enters microwithdrawals, the opioid receptors are suddenly unoccupied, and the craving returns with devastating force.
And then what happens?
That neurological urgency almost inevitably drives a return to chaotic, risky injection behaviors, which of course reignites the infection risk.
So the daily dose essentially demands flawless human execution in an environment that is defined by chaos.
Perfectly stated.
So how does the monthly formulation bypass that?
Well, the subcutaneous injection completely alters the pharmacokinetic landscape. Once administered, BUPXR forms this solid polymeric depot beneath the skin.
Like a little reservoir.
Exactly like a reservoir, and it degrades at a highly predictable rate, releasing a steady therapeutic concentration of buprenorphine for an entire month.
Wow.
There are no daily peaks and troughs. The patient cannot forget to take it, and they cannot sell it. It provides a relentless 247 receptor blockade.
So the stability is built into the chemistry rather than, relying on the patient's willpower every single morning.
Precisely.
That is a brilliant hypothesis to test. But, a brilliant pharmacological theory doesn't mean much if it doesn't hold up in messy, real-world clinical settings, right?
Oh, 100%.
So to prove this, the researchers needed a massive data set, which led them to the Verdime network.
Right. They executed a retrospective cohort study. They were pulling from electronic health records and linked claims data spanning 6 years, from 2018 to 2024.
That's a huge window.
It is, and this allowed them to track real clinical outcomes rather than just, tightly controlled trial data.
And when you look at the raw numbers they pulled, the imbalance is kind of staggering.
It really is.
Because the daily transmucosal formulation, it's been the gold standard for so long, right?
Yeah.
So they had a cohort of 118,112 patients. But the monthly injection is relatively new and historically way harder to get covered by insurance.
Unfortunately, yes.
So that cohort only had 467 patients. Comparing a group of 118,000 people to a group of barely 400 is, well, it's like trying to compare the behavior of a massive packed stadium to a tiny private classroom.
Yeah, the statistical noise in a comparison like that would normally invalidate the findings immediately.
Especially because the cohorts weren't just different sizes. They had fundamentally different baseline health profiles, too.
Very different.
The researchers noted the tiny injection group trended younger, heavily skewed toward Medicaid, and critically, they came into the study with significantly higher baseline rates of skin conditions and hepatitis B and C.
Right. So if you run a direct comparative analysis on that raw data, you are virtually guaranteed to conclude that the monthly injection causes worse outcomes.
Because they were already sicker.
Exactly. That would simply be an artifact of the injection group being sicker and higher risk from day one. So to extract the actual signal from all that noise, the researchers deployed a rigorous statistical adjustment called inverse probability of treatment weighting.
Okay, inverse probability of treatment weighting, IPTW.
That's the one.
I want to make sure we really understand the mechanics of this because it seems like the only reason we can trust the results. Tell me if I have this right.
Go for it.
Instead of just throwing out data to make the groups the same size, IPTW mathematically adjusts the influence of specific patients. So you essentially take the data of a rare, high-risk, younger patient in the massive daily pill group and give them more mathematical weight, almost cloning their data in a way to artificially match the heavy concentration of those exact demographics in the tiny injection group. Is that right?
That is a highly accurate way to conceptualize it, actually. It is an epidemiological balancing act.
Okay, cool.
By weighting the probability that any given patient would receive either treatment based on their baseline covariates, age, comorbidities, insurance status.
You neutralize the confounding variables.
Exactly.
You essentially build a synthetic version of the stadium in the classroom where the demographic makeup, the medical histories, and the risks are identical.
Right. And once that mathematical parity is achieved, the delivery method of the medication becomes the solitary independent variable.
Which is exactly what we want to test.
Yes. You can then look at the 6-month follow-up period and isolate the true impact of the monthly injection versus the daily dose.
And, I mean, the outcomes they isolated over those 6 months are wild. Let's look at the infection rates first, specifically bacteremia, those severe bloodstream infections that lead to the heart valve destruction we talked about earlier.
Right. So, after applying the IPTW to ensure a level playing field, the cohort receiving the monthly BUPXR injection demonstrated a 62% reduction in the incidence of bacteremia compared to the transmucosal group.
Wait, a 62% drop?
A 62% drop.
That isn't a marginal improvement. I mean, that is fundamentally altering the trajectory of a lethal complication.
It is a phenomenal protective effect. It really is. Though we do need to look at the nuances of the data regarding the precursor infections, too.
Like the skin abscesses.
Right. In the raw, unweighted numbers, the injection group also saw a 37% drop in skin and soft tissue infections. However, once the IPTW weighting was applied, to account for their higher baseline rates of skin conditions,
I see.
that specific reduction actually lost statistical significance.
So the data on stopping a surface-level abscess is a bit muddy, but the data on stopping that abscess from turning into a catastrophic bloodstream infection is rock solid.
That's a fair assessment.
And you can see that undeniable impact when you look at the HCRU, the healthcare resource utilization. I mean, if you are a hospital administrator looking at this data, your jaw is on the floor.
Oh, the divergence in hospital utilization is staggering. The monthly injection cohort experienced a 56% reduction in overall inpatient hospital visits compared to the daily dose cohort.
Over half.
More than half, yeah. And they also charted 22% fewer emergency department visits, alongside a 77% plummet in outpatient visits specifically coded for sexually transmitted infections.
Here's where it gets really interesting, because a 56% drop in inpatient visits is not just a win for hospital capacity, right? It points to a profound shift in the behavioral reality of the patient.
Yeah.
Inpatient admissions in emergency departments are the safety nets for acute crises. You don't end up there unless something has gone terribly wrong.
If we connect this to the bigger picture, the mechanism driving this reduction becomes really clear.
Okay, let's hear it.
The continuous, unbreakable blockade provided by the BUPXR depot means these patients are largely insulated from the desperate, chaotic periods of withdrawal.
Right, the micro-withdrawals are gone.
Exactly. They aren't experiencing the acute behavioral decompensation that leads to overdoses or, severe traumatic injuries that require emergency care.
That makes total sense.
But there is an equally critical secondary mechanism at play here, and it's actually embedded in the logistics of the delivery method itself.
You mean the fact that you can't just, pick up a 30-day supply of syringes at the pharmacy and do it yourself?
Precisely the opposite, yeah. The BUPXR protocol mandates that the subcutaneous injection be administered by a healthcare professional. That requires the patient to physically cross the threshold of the clinic and have a face-to-face interaction with a provider every single month.
Which creates a forced, recurring touch point.
Exactly.
So if a patient comes in for their shot and they have a nascent cellulitis forming on their arm, the clinician is looking right at it.
Right there in the room. They
can prescribe a standard oral antibiotic immediately, resolving the issue before it ever has the chance to fester into a systemic infection that requires, an ICU admission.
It forcefully shifts the paradigm from reactive emergency medicine to proactive clinical maintenance.
Okay, but speaking of proactive clinical maintenance, there is a finding in this data regarding outpatient visits that completely threw me at first.
I think I know where you're going with this.
We just went over how emergency and inpatient visits plummeted across the board. But there was one specific category where outpatient visits actually spiked for the injection group.
Yes, the data tracking chronic viral management, specifically for hepatitis B and C.
Right. The study revealed that outpatient visits for hepatitis management were significantly higher in the BUPXR group. It was 10.5% compared to just 4.9% in the daily pill group. And we should briefly note, the researchers pointed out a glaring failure across the board here, which is that very few patients in either cohort received comprehensive infectious disease lab testing.
Yeah, the lack of baseline lab testing is a systemic failure that warrants its own deep dive, honestly.
True. But, okay, let's unpack this. You've just laid out a brilliant argument for how the monthly injection stabilizes patients, reducing their hospital visits by 56% and keeping them out of clinics.
Right.
But now the data shows that hepatitis C visits effectively doubled. How does requiring more medical intervention for a severe liver virus equate to a clinical victory?
It seems contradictory until you separate the fundamental nature of the care being provided. We really have to differentiate between acute crisis response and planned longitudinal care.
Okay, so an emergency room visit for bacteremia is the crisis response. The fire is raging.
Yes. An emergency admission indicates the patient's health has spiraled out of their control. It is inherently dangerous and, frankly, indicative of instability.
Right.
Hepatitis C management, however, operates on a completely different clinical timeline. Curative treatment for Hep C involves direct-acting antivirals, which is a regimen requiring strict adherence, regular lab work, and sustained clinical engagement over several months.
And you cannot successfully navigate a multi-month, highly structured antiviral regimen if you are caught in a cycle of relapse and daily survival.
The chaotic use fundamentally precludes that level of organization.
Oh, wow.
Therefore, the doubling of outpatient visits for hepatitis in the BUPXR group is not an indicator that the injection is causing more liver disease.
No, of course not.
It is a powerful indicator that these patients have finally achieved the neurological and behavioral stability required to actively participate in their long-term health.
They can actually make an appointment and keep it.
Exactly. They are no longer just surviving the week. They possess the bandwidth to show up, do the lab work, and engage in curative chronic care.
That reframes the entire statistic. The numbers go up because the patients are finally stable enough to show up for their own lives.
Beautifully said.
It's a marker of clinical engagement, not disease progression. But as compelling as this narrative is, we have to stress test the boundaries of the research. No deep dive is complete without addressing the limitations of the data.
Very true. The researchers are very transparent about the constraints, and the most prominent is their inclusion criteria. To be counted in this study, a patient had to maintain continuous use of their respective medication for a minimum of 90 days.
Which, purely from an experimental design standpoint, makes sense, right? You can't evaluate the efficacy of a drug if the patient stops taking it after week 1. You need a baseline of exposure.
Methodologically, it is sound. Clinically, however, it introduces a significant survivorship bias. The first 90 days of treatment for opioid use disorder are notoriously volatile. By requiring 90 days of continuous adherence, this data set effectively purges anyone who dropped out early.
So it only looks at the people who are already doing somewhat well.
Right. It doesn't account for the patient who found the monthly injection too painful and never returned, or the patient who struggled with the daily pill and relapsed in month 2.
So if you are analyzing this research, say, to implement a public health policy, you have to remember you're looking at an inherently sanitized picture.
Yes.
These cohorts represent the retention success stories. Real-world medicine is much messier, and this study doesn't solve the massive hurdle of simply getting people through those critical first 3 months.
Adding to that, we must acknowledge the statistical fragility of the BUPXR sample size.
467 patients.
Exactly. Even utilizing IPTW to balance the 467 patients against the larger cohort, 467 is a small denominator when you are tracking relatively rare outcomes.
Like endocarditis.
Yes. Detecting a statistically significant difference in something as specific as infective endocarditis requires massive populations. So the lack of statistical significance in some areas might reflect the sample size rather than a lack of clinical efficacy.
And because this relies entirely on electronic health records and insurance claims from the Veridom network, there are, inherent blind spots in the surveillance.
Oh, certainly.
Like if a patient experiences a severe abscess but seeks treatment at an out-of-network free clinic, or they just pay cash at an unaffiliated urgent care, that data simply ceases to exist in this study.
Observational data will always have those geographical and financial blind spots. It's unavoidable.
But even acknowledging all of those caveats, the survivorship bias, the sample size, the EHR limitations, the core signal cutting through the noise remains incredibly robust.
It does, and this raises an important question regarding the structural future of addiction medicine. Well, for decades, the healthcare system has treated opioid use disorder and infectious diseases in isolated silos. You visit one clinic for your buprenorphine, and you are referred to a completely separate specialist across the city for your hepatitis C or HIV management.
Which creates an immediate barrier to care for a highly vulnerable population. It's like asking them to run an obstacle course just to get well.
Exactly. This study empirically proves that treating the addiction effectively is treating the infectious disease. The two are inseparable.
So they should be treated together.
Yes. The clinical environments administering BUPXR should be fully equipped to handle comprehensive infectious disease screening, vaccinations, and antiviral regimens.
Because the patient is already sitting in the chair.
Right. They're there every 30 days for their injection.
Don't make them navigate a fragmented healthcare maze. Put out the fires in the exact same room where you were repairing the earthquake damage.
Seamless, co-located care. That is the operational gold standard this data points toward.
As we wrap up this deep dive, let's take a quick look back at the ground we've covered today. We started with a medical mystery, basically how the physical format of a drug could alter secondary outcomes. We explored the deep pharmacological and behavioral differences between, demanding daily adherence to an oral pill versus the steady, unyielding blockade of a monthly subcutaneous injection.
And the numbers speak for themselves.
They really do. The data proved that shifting to that monthly injection resulted in a 62% reduction in life-threatening bloodstream infections, while cutting inpatient hospital admissions by more than half.
It is a profound testament to the fact that stabilizing the patient's routine stabilizes their overall physiology. It removes the daily burden, neutralizes the vulnerability of withdrawal, and mandates the kind of regular clinical interaction that catches minor issues before they become life-threatening emergencies.
It really makes you wonder, across the entire medical spectrum, from managing complex psychiatric conditions to stabilizing cardiovascular disease, how many other looming health crises could we solve tomorrow?
That's a great question.
Right. Not by spending billions of dollars and decades in a lab trying to invent a brand new miracle molecule, but simply by finding a smarter, steadier way to deliver the drugs we already have.
That is the exact paradigm shift this research demands. Often the breakthrough isn't discovering a new tool, it's recognizing that how we use the tool changes everything.
The earthquake doesn't have to guarantee that the city burns down. We just need to design a better system for distributing the water. Thank you so much for joining us on this deep dive. Stay curious, and we will catch you next time.